Hello everyone, my name is Alona Kochmar and my curriculum design presentation is What is Lupus Anticoagulant? My target audience for this course is medical laboratory technologists who want to learn about special coagulation testing. This course can also be offered to MLT students who want to refresh their knowledge and learn new methods of special coagulation testing. The objectives of this course are to describe abnormal test results seen in patients with lupus anticoagulant and explain what causes those results. Another objective is to demonstrate how to rule out other coagulopathies and show how anticoagulants interfere with test results and how to compensate for those. Agenda of this presentation is as follows. What is LA? And how to test for it, how to make sure it is LA, and anticoagulants, good and bad, and how to work with anticoagulated plasma. What is lupus anticoagulant? Lupus anticoagulant is an acquired coagulation disorder. That means that can happen to anyone, although in the history it mostly happens to females, although it does happen to males occasionally. During this disorder, patients start producing antiphospholipid antibody. So the disorder is autoimmune. And that antiphospholipid antibody can trigger spontaneous thrombus formation in vivo, which meaning inside the body. And interestingly enough, it can cause prolongation of laboratory coagulation results in vitro, which means in the test tube. This disorder was first noted in people with systemic lupus erythematosus, and hence the name lupus anticoagulant. But later it was discovered that lupus anticoagulant can happen to people without SLE, but the name got stuck. Typical patient is younger, less than 70 years old, presents with unprovoked thrombosis, venous or arterial. It was also noted that people with LA can present with fetal loss at a later stage with morphologically healthy baby. So we're talking about later than 20 weeks gestational age and the healthy baby just dies. Laboratory investigations show prolongation of routine coagulation results. The theory behind lupus anticoagulant testing. Phospholipids play an integral part in clot formation. So therefore, if there is not enough phospholipids present, coagulation test gets abnormally prolonged. People with lupus anticoagulant have antiphospholipid antibodies in their plasma. And routine APTT tests for coagulation, they have phospholipid in the reagent. So therefore, when we mix the patient's plasma and the reagent, the end result is the prolongation of results because the phospholipid in the reagent is deactivated by antiphospholipid antibodies that are present in patient's plasma. So therefore, what we can do, we can run plasma with reagent that has abundant amount of phospholipids, and the result would be normal. The reason why it would be normal because there's still going to be enough of free-floating phospholipids to form a proper clot. And then if we run the same patient plasma with reagent that has very small amount of phospholipids, the result will be drastically prolonged because antigen-antibody neutralization will happen and there won't be enough phospholipid left to form a proper clot. So what tests do we run? APTT-SS is a routine coagulation test that we normally run on patients to monitor their heparin therapy and to measure clotting. INR is another routine coagulation test that we run to monitor anticoagulants such as warfarin or coumadin and also measure clotting. There is another form of APTT which is sensitive, and that APTT is the same reagent as APTT-SS, but it has very small amount of phospholipids. And another reagent is APTT-insensitive. It's the same thing as APTT-SS routine, but that test has a large amount of phospholipids. Another test that we also run on patients to investigate if patient has LA is called DRVVT. DRVT is a coagulation test that's very similar to APTTSS, but it has two reagents incorporated in it, sensitive and insensitive. And the final result is a ratio. And the beauty about the DRVT, why we consider it as a gold standard, because it has the snake, Russell viper's venom, and that venom of the snake, what it does, it bypasses the clotting factor deficiencies. So it activates the clot without, if the patient has, let's say, hemophilia, it will not be abnormal. So this test is specifically designed to detect people with LA. So let's review the results. The typical lupus anticoagulant results are as follows. APTTSS, the routine test, is elevated. APTT sensitive, the one that has small phospholipid content, is also elevated. APTT insensitive, the one that has lots of phospholipids, is normal. And DRVT ratio is elevated. Now, you would think, is that all you need to diagnose lupus anticoagulant? No. There are many occasions when typical presentation of lupus anticoagulant test results when it can mimic other disorders or coagulation therapies. So what we have to do, we have to carefully check patient history and see what was the reason for patient hospitalization, whether it's deep vein thrombosis, stroke, pulmonary embolism, and that gives us the idea that patient is undergoing some sort of thrombus formation. Is patient on anticoagulants? We can also check that. And if APTT is elevated, so it can happen when patient is on heparin, and INR, if it's elevated, it can happen when patient is on vitamin K antagonists such as Coumadin or warfarin. So how do we make sure it is LA? So first thing we do when APTT is elevated, we run mixing study. So we run 50-50 patient plasma with normal pooled plasma, and then we rerun the APTT again. And if our mixture gives us APTT elevated result again, we can conclude it's an inhibitor, such as lupus anticoagulant. If the mixture gives us normal result, we can conclude it's factor deficiency, such as hemophilia A, because normal pooled plasma would compensate for factor deficiency in patient. Anticoagulants, the good and the bad side. When patient presents to emergency with thrombosis, and most of the time the patient is almost always given anticoagulants to prevent further organ damage. And then later on, when the patient is somewhat stable, the doctor wants to investigate what's causing the thrombosis. So the doctor wants to order special coagulation tests. And the doctor draws the blood, and there are lingering anticoagulants present in patient's plasma, and now those anticoagulants can interfere with testing. But there are some ways to correct for it. First, what we can do, we can add Hepzyme to patient's plasma. By adding Hepzyme, the heparin will get neutralized and will get normal APTT value. If the patient has lupus anticoagulant, the Hepzyme will not neutralize it, so we'll still have prolongation of APTT result. Another excellent heparin contamination predictor is thrombin time. So by simply running thrombin time, which will only take a few seconds to do, if thrombin time is prolonged, we can conclude it's heparin. If thrombin time is normal, then we can conclude the prolongation of APTT is caused by lupus anticoagulant. Another test that can be falsely elevated is DRVT, and that's if patient is given vitamin K antagonists. So to correct for that, we can run 50-50 mixture of patient plasma and pooled normal plasma. And if the patient is on VKA, ratio will become normal. And if the patient has LA, ratio for DRVT will stay elevated. So now it's time for evaluation. I'm going to present 3 different case studies, and my co-workers will tell me what they think about the diagnosis. So first case study is when APTT-SS is normal, APTT sensitive and insensitive are both normal, but DRVT is elevated. And keep in mind, DRVT is our gold standard, so we need to make sure that it's normal to rule out LA. If it's elevated, even though other tests are normal, we still need to investigate it because maybe it's a very weak lupus anticoagulant. So what is the most likely diagnosis and what other investigations would you perform? Case study number 2. APTT-SS is elevated, APTT sensitive and insensitive both elevated, and DRVT is also elevated. What is the most likely diagnosis and what other investigations would you perform? And case study number 3, APTT-SS is high, APTT sensitive is high, APTT insensitive is normal, DRVT ratio is elevated. What's the most likely diagnosis and what other investigations would you perform? Thank you very much for watching this presentation. Bye.